Hi, my name is Dr. Leigh Neumeyer, and I am a surgeon. I'm also a professor of surgery and chair of the Department of Surgery here at UF Health Jacksonville. So when you're diagnosed with breast cancer, we use 4 characteristics about the tumor and its presentation that help us determine how good or bad it is, and really help us determine what your treatment course is going to be like, what the choices might be. Those 4 things are whether or not tumors made it to the lymph nodes, how big the tumor itself is, what's the grade of the tumor, so that's what it looks like under the microscope, and then whether or not it has certain receptors on it. So I'm going to go through each one of these and then we'll sum it up as well in the end. Now, these are the 4 things we use, and these 4 things generally combine, actually the first 2, to tell us what stage your cancer is. Stage is really a very gross measurement. That's like measuring things in yards when you really are trying to measure something that's only an inch. And so it gives us an overall big bucket to put things in, but we want to personalize a treatment as much as we can to the tumor that you have and to who you are. So lymph nodes. If the tumor's made it to the lymph nodes and we can find it there, then we're a little more worried that it may have made it elsewhere. Now, we can cure breast cancer up to stage 4. Stage 4 is if you have disease beyond your lymph nodes, so in your brain, your bones, your heart, or your lungs. The next thing is size. So most breast cancers these days are actually diagnosed when they're around 1 centimeter in size, because a lot of them are diagnosed via mammogram. And remember, we can pick something up on mammogram as small as 5 millimeters, and our mammograms have gotten really, really good. If it's above 2 centimeters, it's puts you into a higher stage. If it's below 2 centimeters and the nodes are negative, you can stay stage 1. Grade is what the cells look like under the microscope. So once we do the core needle biopsy, the pathologist will look at the histology and they look for the cells. Now, normal breast cells that line the ducts and lobules are very uniform. So many of you will remember from high school biology that cells have 2 main components. They have the nucleus and they have the cytoplasm. And the nucleus is a little ball, and then there's usually a lot of surrounding fluid called the cytoplasm. In the normal breast, it's 1 layer of cells lining the ducts and the lobules. When you have breast cancer, you start to have the more than 1 layer, and the cells start to look crazy. So more of them are dividing than we would see in normal. They make multiple layers and in fact fill in the ducts and lobules, and then sometimes bust out through the wall of the ducts and lobules to get into the surrounding tissue. That's what makes it invasive. So when the pathologist is looking at that, they grade it in as 1, 2, or 3. So 1 is a well-behaved tumor, 2 is a moderately well-behaved tumor, and 3 is a poorly behaved tumor. Now, a lot of us have experience with teenagers. Either we were a teenager once, or we had teenagers, or we have teenagers, or we're going to have teenagers. And I like to describe the different grades as if they were teenagers, teenage kids. So a grade 1 cancer is like a teenager you left for the evening. So probably they're not going to try and have the party, right? Because they know you're coming back. They don't want to have to clean it up. They just aren't going to try to have the party. So grade 1 that's pretty good behaving teenager. Grade 2 is like a teenager you left for overnight, but you're coming back first thing in the morning. So if you think about that, I don't know about you guys, I have 3 kids, and I had one that was a grade 1, wouldn't get in trouble for anything. One was a grade 2, and that one, is a little more likely if we went for the night to think, they're pretty, got everything under control, and they might try to have the party. Then I also had a grade 3 teenager. A grade 3 teenager is like the teenager that you left for the entire weekend. It's unclear whether you're coming home in the morning on Sunday or later Sunday. And if they don't want to have the party, their friends want to have the party, and they're confident they can get it cleaned up by the time you come home. And I don't know about you guys, but after I discovered I had a grade 3 teenager, I really had to worry more about that teenager. Then the last thing we look at is what are the receptors that are present on your cancer cell, because these allow us to use different kinds of medications to treat that cancer. So the most common kinds of breast cancer are what we call hormone-positive breast cancer. So this means that those cancer cells have docking stations for the hormones that our bodies make, so estrogen and progesterone, and this is the hormone. You got to get my hand motions here. The hormone docks into that receptor, and then that stimulates the cell to divide. We have now, so if you have estrogen and or progesterone receptors on your tumor cell, we have medicines that can block that receptor. Those are medicines called tamoxifen and raloxifene. And we also for women who are postmenopausal, we have the ability to block this step for estrogen that's manufactured outside the ovary. We can block the step from pre-estrogen to estrogen, so we can keep your body from making estrogen. And we actually have about 5 different choices for that kind of drug. There's also another receptor that we look for on all breast cancers, and that's called the HER2 receptor. The HER2 receptor is a receptor that is actually a marker of an aggressive tumor. And we used to say probably 20 years ago, oh gosh, this is a HER2 positive cancer, this is really, really bad. But around 15 years ago now, there were a couple of drugs, biologic agents, monoclonal antibodies that were developed that basically attach onto the HER2 receptor. And the HER2 receptor is actually only expressed in a couple places ever, and that's on breast cancer and occasionally on some receptors in the lung. So this is a very specific kind of like heat-seeking missile. So Herceptin, and it's actually got its generic name is trastuzumab, and then there's a couple other variations of it that we have now, so we can do double and triple therapy for that, have been very effective to the extent now if you have a HER2 positive cancer, we in many ways almost cheer because we know we have very effective medicines that will only go there. Chemotherapy is meant to kill any fast-dividing cell. So when patients get sick from chemotherapy, like they lose their hair, that's because the hair follicles turn over your hair. You know, your hair grows, that's why you get the gray hair grows in around your color and things like that. And that's why people lose their eyebrows and their eyelashes, because the chemotherapy wipes out the cells in the hair follicles. You get sick to your stomach with chemotherapy because, again, it's very nonspecific, is killing any fast-dividing cell. And the lining of your stomach turns over about every 7 to 10 days. That's why you're more prone to infections with chemotherapy, because your blood cells turn over very quickly, both your red blood cells as well as your infection-fighting white blood cells. If you don't have any of those receptors on your cells, in particular if you don't have the hormone receptors on your cancer cells, then you're most likely going to get chemotherapy as a part of your treatment. So if I was to sum up again, we have these 4 things that we use. Lymph nodes. If you have tumor in your lymph nodes, your chance of needing chemotherapy as part of your treatment, the systemic treatment of your cancer, is much higher. Although these days we use a lot more, especially if you're hormone positive. It isn't always a guarantee if your tumor is hormone positive. If your lymph nodes don't have tumor in them, then we use the size, the grade, and the hormone status. So we use all these things together to help us determine who's going to get chemotherapy. Frequently, once you have the diagnosis of your breast cancer, we know the receptor status, we know the grade, we have an idea about the size with the imaging, and we also actually have a pretty good idea about the lymph nodes also with the imaging. Then we can have a pretty good discussion about what we think the chances are of which part of the multidisciplinary therapy you're going to need. And most importantly, I like to try to address early on my best guess as to whether or not the patient's going to need chemotherapy, because I think that's the thing that scares the patients the most.